regarding it? मतलब कुछ है अपना brochure दूसरा कुछ है आगे?
Yeah. The initial brochure and announcement, all those things are there. No? Chetan, do you have or shall I get from Ravi Shankar?
I have, but it was older one. I'll ask Ravi Shankar.
Ravi to get one. Yeah.
Doctor,
And Tapisha from
sir,
Delhi side.
Dr. Dinesh?
Sure, sir. If someone can just forward the,
Yeah.
the
And
WhatsApp
just
forward and
forwarding,
circulate.
just
Good evening,
forwarding
sir.
won't work.
Dr. Dinesh Tiller, sir.
Oh, hello.
Hi.
Welcome, Dr. Dinesh.
Hi. Good evening.
Dr. Dinesh, can you just share your one
Good evening,
PPT, introductory PPT in the group? If it is ready.
Yeah, I have
or
something
I'll
ready.
say Rainbow Children Hospital, right?
He doesn't need any introduction. The
I
whole
know,
world
but still.
knows.
One sentence which is
Yeah.
appropriate.
Yeah.
Good evening, Dr. Dinesh. Honored to have in the panel.
Hi. Good evening, madam. Good evening.
I
So
was
nice to see all of you.
fortunate to catch hold of him.
Yeah, yes. When Chetan told me Dr. Dinesh has agreed, I was a little bit, I was thinking of.
There are very few entrepreneurs in neonatology or pediatrics, and Dinesh is heading the list.
Yeah.
That is how he should be introduced. He is the best entrepreneur in the list, in the group.
I think you say ना entrepreneur by chance जैसे रहता है ना वैसा है वो by chance.
जो भी चांस है अच्छा चांस है ऐसा बोल सकता हूँ.
Manish, are you on laptop?
Yes.
Then can you log in with this our PIDA?
Yes, I'll do.
So that I can at least, if at all my connection is not stable, it will continue.
Yes, I'll join to PIDA.
Okay.
Good evening, sir. Good evening, ma'am.
Good evening, Dr. Devdeep.
Hello, sir.
Welcome, Dr. Devdeep.
Thank you, sir. Thank you, sir.
Yeah. At present, Devdeep, you are at Health World Hospital, right?
Yeah, that's right, sir. Asansol. It's around 200 kilometers from Kolkata.
Okay, fine. Good evening, Dr. Gorpade.
Yeah, good evening. Good evening, Chetanji. Good evening.
Welcome.
Yeah, good evening. Good evening, Dr. Bhaskar.
Yeah, good evening. Good evening. You are still full-fledged.
After a long time, actually, I am seeing the face of our chairperson. Good. Dr. Dinesh, good evening.
Good evening, Dr. Sanjay. How are you?
Fine.
Nice to see you.
Yeah. Kaya?
Yeah, good evening, sir.
Yeah, good evening. Are you ready? Good.
She is ever ready.
And Chetan, you have chosen the right person for right panel.
Oh, Chetan always does so.
We have to do only that thing. Rest they are doing.
Yeah. Good evening, Dr. Devdeep and
Good evening, sir.
Dr. Tapisha, madam.
Good evening, sir.
Manish, you are host right now. Manish?
Kaya, again, can you blur the background, Kaya?
Yeah.
Yes.
I switch off. I am doing it. Okay.
So you are host right. Okay, fine. It's 9 o'clock. Okay. Good evening, everyone. We are here for our Super 11 series, and it is the brainchild of the person who has just appeared on the screen, Dr. Balasubramaniam sir.
Welcome, sir.
It started long
Welcome.
back last year, and now it is been so appreciated that we are now continuing this Super 11. Now it is going to Super 22. So this time, and since last 2 or 3 links, we tried absolutely case-based discussion. And that's what the thought of our present chairperson, Dr. Bhaskar Shenoy. And then we started with interesting cases. Then we did in PICU. Then we thought of let us talk about neonatology. So today we are at link 16 of Super 11. Let's decode the interesting ID related cases in NICU. So now I'll request Dr. Bhaskar Shenoy, the chairperson of Pediatric Infectious Disease Academy, to say a few words.
Good evening, respected seniors, Dr. Bala Subramaniam. I think as Chetan told, it is the brainchild of Dr. SPS. We have today, and Dr. Sanjay Gorpade, our incoming chairperson. We have a very nice discussion today on neonatal infections, decoding the neonatal infections, which is rather untouched. And to address this, we have a galaxy of experts, Dr. Dinesh, Dr. Devdeep, Dr. Tapisha, and Dr. Ashish Mehta. And it is moderated by none other than Kea, who is a master in neonatal infections. So without wasting much time, I think let us enjoy the scientific feast of today's evening. Thank you so much.
Thank you, Dr. Bhaskar. So I'll request Dr. Gorpade to say a few words, please.
Really, this is a superb going the program of the ID chapter with the hit. And I think this will be remain in continuation in my tenure also, Bala sir. I am assuring that only thing that academic part must be taken care of you as ID chapter forever. And whatever the things going really fruitful for all the pediatricians across India. With this brief introduction, I really seeing the panelists today. There is combination of the neonatologist, Dinesh is there, Devdeep is there, ID expert Tapisha, and of course KI is mix. I think hybrid. KI is hybrid. He is the ID as well as the neonatologist. That good combination is today. So really, I personally joined today to hear the what actually the cases are they will be discussing, and really everything across India or everybody across India will be enjoying today's program. Wishing all the best for the program. Thank you.
So now what we know that yes, Dr. Bhaskar, you want to say something?
No.
Okay. So what we have, we are going to discuss interesting ID cases in neonatology. And that's why we have Dr. Kea Ghosh. She is, of course, a neonatologist and hardcore ID consultant. So she will be, she's given a responsibility of managing biggies in neonatology, like Dr. Ashish Mehta, who is an authority in neonatology. He doesn't require any introduction. He's been very well known all across the country. Similar, the name is Dr. Dinesh Chilla. He's a chairperson and director of Rainbow Children Hospital. I think he also doesn't require any introduction. We have to balance this neonatologist. We have one neonatologist from East, that is from Asansol, is Dr. Devdeep Mukherjee. He is the senior consultant neonatologist and pediatricians at Health World Hospital, Asansol, West Bengal. Welcome, Dr. Devdeep. And to balance all these neonatologists, we have Dr. Tapisha. She's an ID expert from Max Hospital, Delhi. So it's going to be a very interesting discussion. I'm very sure. Let's see how the interesting discussions go and how best we learn the neonatology as well as the infections. So over to Dr. Kea for the discussion. Thank you.
So thank you, Chetan, my chairperson, everyone, Dr. Bhaskar, and for so kind words. And we are here to discuss some of the interesting cases. We will not go into the hardcore neonatology part. We will just go into the infectious disease part. And as mentioned by Dr. Chetan, we have a galaxy of panelists. So let's, I hope you can share, you can see my slides.
Yeah. Yes.
Yeah. Okay. So within the next 1.5 hours, we will try to cover 8 cases I choose. If time permits, we can go for 1 or 2 more. So without wastage of time, let's start our discussion. Moving. Just to start the ball roll, as you all know, neonatal sepsis is the major contributor of neonatal mortality globally. And in India, it is also it contributes to a major chunk of NMR. So in NMR in India, if you see, there are three major chunks: the sepsis, the prematurity, and perinatal asphyxia. Out of this, even in the prematurity cohort, we have around 40 to 50% of this cohort. The death is attributable to infection only, because as with the advance of preterm care, we are able to treat the other complications of prematurity very efficiently. But okay, again, we are lacking in the infection part. So, but this neonatal sepsis related mortality, it can be largely preventable with good prevention of infection. And of course, hand hygiene is the leading amongst this. Early recognition of the neonatal sepsis, aggressive supportive care, along with rational antimicrobial therapy. So this is the most important. We have to be rational. Though the case fatality rate of sepsis among neonates ranges between 25 to 65% in India, depending upon the center involved. So we are always scared. We start antibiotic, sometimes irrationally. And but we have to also understand there is a growing threat of drug-resistant infections in newborn, and antimicrobial resistance is causing more harm. So to have a balance between this high case fatality rate and a high antimicrobial resistance, the only answer is judicious use of antimicrobials. So in the coming cases, we will discuss exactly on this point whether we were right in using the antibiotics and what should have been the better. So let's, with this background knowledge, let's move on to the first case. This is a 21-day-old girl baby who came to us with complaints of poor feeding and decreased urine output for 4 days. As you know, all neonatal sepsis comes in a very subtle way. So it may be a manifestation of hypothermia, hypoglycemia, and so on. So this baby had a second child of non-consanguineous parents, and the birth weight was 2.8 kg. There was emergency LUCS done due to cord entanglement, and there was a little bit of respiratory distress. The baby required oxygen supplementation in a local nursing home and discharged home after 4 days. She was doing better and came in the 21 days with this features. There was decreased urine output. Of course, there was a little dehydration. So may I start with Dr. Ashish. Sir, what are your thoughts and how we will investigate and which antibiotics to start with?
Yeah, thanks for opportunity, first of all. Nice to be amongst the leaders of the leader here, I can see of the ID chapter. Now, this is a 3-week-old baby who started with some distress, required some admission for 4 days in one nursery, and then ends up with poor feeding and decreased urine output. Of course, I'm sitting in ID symposium, so of course I will not be talking about ID to begin with. This is a case, this is a scenario which can happen to any baby because of any reason. And reasons are many. First thing that I would like to see, poor feeding is recent, or is that happening for what is happening for with the feeding of this baby for last 3 weeks? So while I like to look at the weight of the baby. If you see here, this is a 32-weeker with 2.8 kg. So, and if you look at the centile of the intergrowth, I'm pretty sure I don't know the number at the moment with me, but this is a little bigger baby. 32-weeker, we expect somewhere 2.5. This is a 2.8 kg baby. So that is coming to my mind first, that why this baby was little bit macrosomic or the higher on the centiles number 1. I also like to have an entire story, what's happening with this baby. Was there a sudden, what was happening in the liquor and all those things. And after 2.8 kg baby, 2.8 kg, 3 weeks, baby mother had gone to the pediatrician or the nearby doctor. And what was the weight of this baby in last 3 weeks? Was that baby is gaining weight or not? Having this is the first part. Second thing, I like to look at the feeding history, whether mother was feeding well or not, mother had enough secretions or not, latching was fine or not. If that was not the case, the top feeds were given properly or not. All this combined together, first part will become hydration part. So if the baby was hydrated well, fed well, and suddenly this has happened, then the thing will be, my thinking will be on the other side. Means I'm looking at the pathology then. So initially, common is common feeding issues, weight gain issues because of the poor feeding. And then comes this insult where suddenly for last 4 days, there is a history of poor feeding and poor urine output. Now, this can be because of any reason. There are certain anatomical problems like subglottic cyst, hemangioma of the airways, where baby starts difficulty in sucking and swallowing with 3 to 4 weeks of the life. Gradually, they come with excessive crying and poor weight gain. The pathology is different, complaint is different, because all baby will have poor weight gain and excessive crying to begin with when they come with any pathology. So we need to keep anatomical problems of the airways, sucking, swallowing in the mind, number one. Number two would be because 3 weeks and now poor feeding and lethargy and urine output is poor. I will like to look at the inborn error of metabolism, because that's the one which also comes out after some day of the life or because of some major or minor insult it manifests. And always infection is there in the mind or at the back of the mind. So we like to rule out infection also. So how to investigate? Yes, this will require admission. Whether IV to be started or not, I look at the baby's clinical condition. If everything is fine, hemodynamic is stable, I'll start with rise to feeding on this baby before putting IV line. But I'll definitely collect all the investigations. This will be in form of blood gases, electrolytes, LFT in form of SGPT at least, and then look at urea creatinine, looking at the blood gases, looking at the anion gap, looking at the urine output, urine routine micro, which urine intake infection can also come like this, which is not uncommon in human population. Of course, there is no fear, but there is nothing abnormal. And along with that, we set the blood culture and look at and we'll take it further from there.
So thank you, sir. So would you like to start any antibiotic for this? Or as you said, you would like to see the reports first and then go.
I'll collect the culture. I'll ask for the investigation which will come within 1 or 2 hours. There is no rush in starting antibiotics.
Yes. So we send the electrolytes and the creatinine was a borderline a little bit on the higher side with a little bit high urea. But the total count was 18,100 with a neutrophil of 48%, platelet 75,000 with a CRP of 205. And regarding the feeding history, the baby was feeding well after the discharge in the initial first 10 to 15 days. There was no documented weight gain in the year because they have not gone to any of the pediatricians and came to us just after this problem occurred. And we as thinking to be obviously sepsis is one of the commonest DDs. So we thought it to be a late onset sepsis, and we sent blood culture, urine culture, did and also CSF, and urine and CSF study was within normal limit, and the blood culture was sent. We started with a first line antibiotic because now the sepsis screen is more or less positive. You can see a little bit more than 15,000 count with a CRP of 205. And we are not debating on the first line antibiotic because it might differ from unit to unit depending upon the flora. So our first line is because ours is basically outborn. We cater mainly the outborn newborns. So mostly we get the bugs which are usually resistant to cephalosporin. So initially we used to have cefotaxime as the first line. Now our first line is piperacillin tazobactam, and we started in that. And so it was going on. So on day 3, the baby started to have spikes of fever, which is, as you know, it's not very common in neonates, but spikes of fever, 101 degree Fahrenheit. So we repeated the count. It increased to 23,700. 70% neutrophils with a CRP increased to 276 milligram per air. So now blood CS said flat because they can't tell you the organism at that. So there was a little bit of distension also abdomen. So we did an ultrasound, and to our surprise, we got a well-defined hypoechoic SOL seen in the right lobe of the liver anteriorly, another small size lesion in the same lobe. And there was a little bit of portal venous thrombus. So now, Dr. Dinesh, so what is your diagnosis? Do you see commonly liver abscess in a neonate 21 days old? Now, of course, 24 days old. And what are the risk factors and the common organisms involved?
Yeah, thank you, madam. Thanks, Infectious Chapter for inviting me for this wonderful sort of session. I think as we are now sort of coming closer to what is the cause of and this is not very common. We don't see liver abscess as common in newborns as we probably see in the later age groups. So I think when any child, as very nicely put by Ashish, is we need to know why the child is deteriorating. So let us look out all the non-infective is gone. We are now focusing on infective causes. And to know why the liver abscess, probably we need to know what happened to the child in the neonatal period when was admitted. So things like, did the child have any umbilical catheterization or anything like that, abnormally placed catheters? Because many a times, we do find that, these are the children who are high risk for liver abscesses and other things. Clinical clues like anything on the skin, any rashes, skin, lesions, or also gives you some clues about what type of organisms you might be facing in these children. We also have seen, see, all the lesions which you see in this thing, you have to see whether there's enhancement or not on ultrasound, because we have seen some hepatic AV malformation also. Some space occupying lesions in the liver don't necessarily have to be, but here we have very high CRP and high white cell count, and child is mounting fever, and others are negative, which nightly is put on, because we have to definitely do a CSF for any child presenting with the late onset sepsis, and a urine examination. Both you have said is negative, so that's the reason why we probably are looking at more. But things which have to be looked at: did the child have any umbilical sepsis or omphalitis, catheterization done, any skin lesion, was mother had any chorioamnitis, untreated infection in the early part? These are something which gives a cue why this child had sort of any abscesses which are there. Now, coming to the organisms, see, the common organisms which do present, like E. coli, Klebsiella, are the ones which we see. But, staph is something which can be seen, especially but it's again based on what organisms are there in your unit. If you have a lot of staph colonization in your unit, probably, staph will come higher up in your things. But even the gram negative can cause, especially in the smaller babies, even fungal liver abscess are also been reported.
Yeah.
Candida abscess have been reported. If you have been on TPA, and malassezia has been also reported. So it is based on what are the organism in your unit, you'll have to start suspecting. But at least you have to find where the focus is, and then start thinking about what could be your next line of action in these babies.
So very, very well said. So as you can see, this baby neither have any of the risk factors for hepatic abscess. So there was no umbilical catheterization, no history of any like exchange transfusion or something like that. But portal vein thrombosis was seen as a very rare complications, and no skin markers which will point out toward the Staphylococcus aureus infection. But really, as you have mentioned, we can see all this polymicrobial infection or Klebsiella anaerobes are also. So with thinking that, we upgraded our antibiotic to IV meropenem. Maybe you might argue why so, because the baby was not at all improving. And again, we repeated the counts and the abdomen ultrasound, whole abdomen, because it's already 3 days gone. Usually, if the baby is not responding with the antimicrobials, in a case of hepatic abscess, you can think of surgical opinion. So that's why we repeated an ultrasound. Now, to our surprise, there was enlarged liver with now multiple abscess in both lobes. It was initially in the right lobe. Now it's a multiple abscess in both lobes. Portal vein was now dilated and lumen showing echogenic content and no color flow. So just it was a thrombus was there. So Dr. Devdeep, so how you will manage such a case? Now it has become a multiple small abscess, each measuring 1.3 to 1.6, the largest one. So all were very small. And what will be your take on this?
I think anyway, this was quite a challenging case to begin with. I mean, liver abscess in a neonate is extremely rare. And then to have multiple focuses of this abscess or multiple collections in both the lobes of the liver makes it more challenging. I mean, if you have an isolated abscess in a particular segment, having a pictal catheter and draining it and targeting therapy appropriately makes it more easy. But what was much more challenging over here that we can see is multiple abscesses spread out in both lobes of the liver. So an intervention at this point was extremely difficult, because how many areas would you end up draining? So I guess with antibiotics being upgraded, and we are still waiting for the cultures, it's best to continue with the antibiotics over here and see what is happening. Once the cultures are available, we can then think about upscaling or modifying antibiotics accordingly. And the other challenge over here was a thrombus, so which was there in the portal vein. So that again needs the coagulation to be closely monitored, heparin to be started as well, and then a call as per the clinical response of this child.
So absolutely. So we started enoxaparin, we taken a surgical opinion. They advised to treat conservatively, of course, within multiple abscess of small size, you cannot do anything. And meanwhile, the blood shows MRSA sensitive to vancomycin. So we added vancomycin. In fact, we added just on the day of report only. We didn't wait for the culture report to come. Once we saw multiple abscess, though there were no skin lesions suggestive of any MRSA, but we started vancomycin. So the baby is now on IV meropenem and vancomycin. So at day 13, the baby suddenly developed to have pitting edema. The fever was not there, but the baby started to feed also well, but developed pitting edema, distended abdomen. And so what is your thought and how we will investigate? Now we are giving a vancomycin also. So initially the creatinine was a little more high, but it came down, of course. So how to investigate further? Though I think it's not an ID related question, but still. Okay.
Yeah, but basically this is looking like a pitting edema liquid because baby is sick. And now 21 day baby came to us. This is 13 day more. So we're looking at 1 month old baby who is not being fed properly.
Absolutely.
Not feeding for last 15 days, it seems. And in a sick baby not feeding well, it ends up with a hypoproteinemia. That is what will come to my mind first. Second thing is that we know there is a thrombus, so it has gone to the renal side or IVC and causing obstruction there. And because of that, there is edema that also need to be looked into. So the Doppler is another thing apart from the LFT protein and the Doppler. That is what is required to make sure that things are all right. And nicely, when echo was already done, so need to look at some cardiac problem, whether this has gone to the heart, pericardium, or valves. Need to look. So that is already been done, and we can see here that LFT was already showing low protein, for which the 20% albumin was given perfectly all right.
Absolutely, sir. So again, the edema came down. Day 17, the abdomen distension suddenly increased, where we developed respiratory distress and tachycardia. As you can see, it's a very sudden onset thing. Required respiratory support. Of course, you can understand what is going on. There was dirty green nasogastric aspirate. Baby looked pale. BP started falling. We have to start noradrenaline support. Feeds were stopped, and baby was put on TPN. Dr. Dinesh, though it's quite obvious, but of course, I would like to know your what is your thought?
Two things, I think. I may not be the right person to talk in the ID about the antibiotic. But see, you have a child who had MRSA, vancomycin, we're not improving. And many times we go through that. And then we say, was it a time for us to think about other drug? What is the role of combination drugs? Whether we should have talked about linezolid? What is the role of percutaneous surgical drainage of the abscess? These are something which probably would have gone through my mind as a neonatologist. That was one thing which was going through my mind while I was going through the case. Then coming to this acute episode where the child has got an aspirate, looks pale, and requiring antidote support, either it has to be some acute event where some of the abscess has burst, opened up, and there is an acute abdomen. Sometimes sepsis per se can cause ileus and those sort of things, which is causing this type of child sort of just progressively getting worse and then leading into this. These are some of things which is saying, but we know there's a surgical abdomen. And the clinical clues would be how much is the abdomen distended, what is the color of the skin of the abdomen, should I put a probe and see what is being happening into the abdomen, should I put a drain and see what type of fluid is coming out. A lot of time you just put a needle and say what type of liquid is coming out, and that will give us a clue, okay, should I call my surgeon and just sort of try to open up these things. But this is what is going through my mind as the case is progressing.
Yes, so we did an bedside USG and also did an X-ray. It shows this, of course, can see the baby was enoxaparin, but then also we put a drain. We just put a drain in the bedside. Often here the surgeons they put a drain and then put a gloves drain. I don't know whether you do on it, but we counsel the parents. This require a surgical exploration. Meanwhile, of course, the INR and epitative were a little raised, so we have to stop enoxaparin and prepare the baby for next day for a surgical laparotomy. And exploratory laparotomy shows ruptured liver abscess with intraperitoneal pus. There were, as you can see, there were pus points in the falciparum ligamentum also. So drainage of hepatic abscess. Usually the indications are solitary large abscess on failure of medical therapy or impending rupture signs or multilocular abscess which is not resolving, provided again the surgeons in your unit are expert enough to do USG guided or percutaneous. So truly speaking, our surgeon was not very much expert about it, and we have to go for exploratory laparotomy. And of course, when the diagnosis is uncertainty, often we do an aspiration to see whether it's pus coming or not. But definitely early drainage improves outcome, and it was maybe not properly managed by us because we couldn't get much help from the surgical colleagues, and this lead to rupture of this abscess. But the surprising thing, we were giving a vancomycin sensitive MRSA. We are treating with vancomycin proper doses, but the peritoneal fluid culture again showed MRSA. They thought, so what are your plan now? So
I
should
think
we
at
continue
this point,
vancomycin, as already Dr. Dinesh has said? Should we add something?
yeah, I think
This MRSA was also sensitive to vancomycin.
I mean, at this point, we have to start thinking whether we need to go with multiple antibiotics or change the antibiotics and see the response. And we also have to get our infectious disease colleagues as well and see what is happening with the drug MICs, how sensitive vancomycin was for this child. And back of the mind, we also have to start thinking about whether any immunodeficiencies are ongoing with this child, which needs to be looked into in the longer run. So, but
Yes.
yes, there is MRSA which was there in the blood culture and it's there in the peritoneal fluid, despite this child being on vancomycin, which definitely hasn't been that effective until now.
Sir, want to add
Yeah,
something, Dr.
basically we
Ashish?
give vancomycin, you're right, MRS is sensitive to that. But then we need to look at the peak and trough level of vancomycin, which is not being done
Absolutely, sir.
routinely in our day-to-day practice. Even in right setup also, it's not that cost effective. And that's why we are not sure that adequate dosage were given according to this baby's requirement. So we can't say that vancomycin was given, still MRSA was there. Whether it was effective or not, that is a different thing.
Absolutely. And I think source reduction was also not there. It may lead to this. So we used to learn from our MBBS that whenever there is pus, just drain it. And otherwise infection doesn't get controlled. So this post-operative has a stormy post-operative period, has to be intubated for 1 or 2 days, but gradually the baby became well, was going very fine. So we thought of plan a 28 days course of antibiotic. But day 25, there was also a persistently falling platelet, and repeat blood Cs was sent. And any thoughts, Dr. Tapisha, would you like to?
Yeah, so I think as we discussed earlier, this is a slow to respond liver abscess. Also, a neonatal liver abscess is unusual when there are no underlying risk factors. You've done source control, you've given adequate antibiotics. So you also have to look for a primary immune deficiency because SCID could present in this age group. Although we've seen the lymphocyte count is quite adequate if we look at the TLC and the lymphocyte part of it. And whenever you have any such abscess, you have to think of CGD and chronic granulomatous disease. One of the signature pathogens is staph, and if it's available, you have to send alongside the tests for it, which is NBT, which is I'm told quite cheap and better availability is there compared to DHR, which is the other test.
And should we add antifungal or falling platelet?
Yeah, the platelets are falling, prolonged stay, post-surgical.
All risk factors are there.
All the risk factors exist, yeah.
So, but we just withhold because we thought, let's see at the blood culture. The fungal culture came negative. So as suggested, as thought by you also, we also thought of there may be some disorders of immunity. So we sent NBT DHR assay for CGT, which came out to negative. We did a lymphocytic subset also, which came out to normal. Fortunately, this baby improved. And by another 7 days, we switched over to linezolid, and we could discharge the baby with linezolid. Came for follow-up within blood counts done. There was no suppression, and the baby is doing well. So the learning point is always look for hidden focus in all newborns with sepsis. Think of liver abscess or deep-seated abscess, though it's not very common, but think of it, do an ultrasound. And if especially there is a history of umbilical catheterization and DPN getting in a preterm baby, early surgical exploration may an adequate drainage would have get a better response. So do source reduction. So remember, the source reduction is a very, very important part of any management of infection, and spontaneous deep-seated sepsis should warrant us to look for inborn errors of the immunity. So now PID is better called as inborn errors of immunity, and I think we should look for it. Yes, Dr. Dinesh, yes.
Just one thing, from
Yeah.
we looked at the immunodeficiency, but we have to look at if there was no catheter, what was the cause of the thrombosis in this child, and what could have predisposed, whether that was the reason why everything started, and
Yes,
may
sir.
have to look into at later stage. And sometimes we find and things like protein C, protein S deficiency.
Protein is. So as there was no other involvement, we thought of investigating for protein C, protein S, but ultimately the baby improved. But of course, sir, it's a very well point. So we also discussed, we have recently seen a protein C, protein S deficiency came out with a for purpura fulminans like a picture, and so but in this case we thought, but we didn't do. Of course, we have told them if there is any recurrence of any symptoms or any abscess, or we might have to do. Yes, sir. So Dr. Ashish, should you like to?
With multi-drug resistant bacteria, the vaginal colonization, babies are colonized with resistant bacteria, and the procedure has been done in form of umbilical catheter. In the last 5 years, we have seen 3 neonates with liver abscesses. They are otherwise healthy babies, but because of simple hypoglycemia, catheter has been put, umbilical has been put, or because of simple surgical cause, it has been put, and then they end up with liver abscesses. So we need to keep in mind that the procedure with colonization babies with the resident organism can lead to this problem.
Yes, so we took a very little history, especially in this case. There was no history that made us to think of maybe some immunodeficiency, but all report came normal. So moving to our next case, which is 35-weeker baby with a birth weight of 2.5 kg, referred from another hospital on day 19. There was a history of cold and cough from day 5, treated at home for 8 days. At day 13, the patient collapsed, was brought to an outside hospital in a gastric condition where they put the baby on ventilator, was on multiple antibiotic. I should say they were very haphazard use of multiple antibiotics, but not improving, so transferred to our hospital. And there was a total count was 60,900 with a neutrophil of 75, and the CRP was 51.2 with a platelet good 2.17. Chest X-ray showed pneumonia. On the day 19 itself, came in the night, the resident only could find a pansystolic murmur. So we did an early morning echocardiography, and which revealed DORV with a non-routable VSD, severe PH and PDA. So we started with a supportive treatment for shock and pulmonary arterial hypertension. We continued meropenem only, developed one episode of convulsion. Now the question is, the residents was asking, already the child has, the baby has received so many antibiotics, should we do lumbar puncture? So of course I will learn from the experts, but we did CSF, we did it on the day of 20 and showed 50 cells. Polymorphs was 58% with a glucose 44 and protein 144. CSF culture, no growth. And in blood culture, we could get MR cons. So as we know, the lumbar puncture report varies the counts. So does antibiotic use alter the picture? And MR cons, is it a concern? Which antibiotic? So would you like to give to Dinesh? Huh?
Yeah, I think, see, any child with,
Go ahead, please. Yeah.
sorry, you asked me.
Anyone, sir, anyone, you can answer.
Okay.
Yeah, Dr. Ashish.
Yeah, basically, sorry, go ahead.
Go ahead. Sorry, yeah, please.
Basically, I mean, looking at the whole scenario, this is quite a sick baby at the moment, being treated with the antibiotic, effective, non-effective, sensitive, non-sensitive. But any baby with suspect of the sepsis, urine culture and the CSF is must.
Yes,
Normally, CF urine is being ignored at times, though it is difficult to collect in females. But still, please make it a point to send CSF and the urine as a routine for all babies where the sepsis is first in your mind. And
Yes,
we know that, believe me, that if you look at the 60 references or 70 references, all will give different numbers for the normal cell count, normal glucose, and normal protein. In general, anything more than 20 cell little per term or preterm babies, we always take its abnormal number, and that is to be treated with energy, mean with full antibiotics till we get all the cultures in our hand and till we get the proper clinical scenario. Protein more than 120 is always abnormal, more than 150 in preterm babies, and similarly glucose of less than 33 and 23 for the preterm and term is abnormal. So question is that whether this antibiotic will change the picture or yes, it will change. And it's rightly been stated and shown over here that parameters take time to normalize. So glucose will come first, then WBC and the protein will get normal. But cell is the first one which will come to, which will disappear because the inflammatory reaction has gone down. So cellular response will go down. But CSF is must, I must say that.
Yes, absolutely. So use of antibiotic, the gram negative, the gram the smear will be negative and the cell might come down, but the biochemical parameters might take a time and protein takes a long time. So as sir has very nicely told, so wide range of values with varying sensitivity and specificity. So it's my earnest request, please use your own, and the most accepted ones, as sir said, in term babies, it's more than 20 to 25, and in preterm 25 to 30, and cutoff of protein 100. Sir, we take 100 as in term and 115 in preterm, and of course glucose 33 and less than 23 in preterm. So with this, so we added because it was a MR cons in blood, and we had a CSF because CSF gram stain will not come and the culture also may be negative. So we added vancomycin, which is the drug of choice for CNS cons meningitis. And we have, but this baby had worsening ventilator setup, new infiltrates on X-ray. So we send a BAL PCR. Again, came out a pseudomonas, which was sensitive. It was a good pseudomonas, I should say. So it was sensitive to amikacin. So we just added amikacin. So the baby is now on mero, amikacin, and also vancomycin. So would you like to stop meropenem because you have got cons? So anyone wants to stop?
Yeah, I think it's a brave decision. See, I think you always find
I'll stop. I'll stop. If it is pseudomonas and things, I'll stop.
Yes, sir. Sir, I think if you are very rational, you should stop. But truly speaking, we continued in this baby because the baby was very sick. And so baby was extubated, gradually feet started. Then day 32, there was recurrent episodes of hypoglycemia along with leukocytosis with a neutrophilic predominance and increasing CRP. Platelet count was normal. So we again sent a repeat blood CS. Sir, as you mentioned, we always routinely send a urine RECS whenever a late onset sepsis comes along with the CSF. So on day 34, there was few episodes of seizure. So should we start empirical antifungal in this case, or so what is your comment on antifungal prophylaxis in NICU, sir? Dr. Dinesh, please.
See, antifungal prophylaxis is based on what is the incidence of fungal infection in your unit.
Absolutely, sir.
So if you're having a lot of fungal infections coming in your unit, especially when you're dealing with a lot of extremely low birth weight babies, then there you have fungal prophylaxis. And the risk factors are more of people on prolonged TPA and extremely low birth weight babies, surgical newborns. They're the ones who are at high risk of sort of long-term antibiotic exposure. When it comes to this child, when they have child has seizures, especially with having a background history of meningitis, the problem could be a complication of meningitis, like child could have an abscess sitting there, ventriculitis happening, some infarct happening, something like that, which you could rule out that the child didn't get completely treated, and whether we should look into that part is one option. Our second option is it a newer nosocomial bug after child got better? Is child has acquired newer nosocomial bug, and that is when you start suspecting a fungal. So I think any child who is deteriorating after getting better in your NICU, then start looking at what are the common bugs which you see in your unit and these things. And if fungal is what you see, I would probably think about it. Now, when you say thrombocytopenia is not there, see, one of the things which commonly many a times is fungal is associated with thrombocytopenia, and that's how people would say it's not necessarily. I always feel that people overreact to thrombocytopenia. There are so many reasons for thrombocytopenia, including drugs and other things. And but yes, here, if you say, would you consider fungal? I will definitely would consider fungal, but I would look about all other causes which I spoke earlier. Is it the existing infection? Is it a complication of meningitis? Should I repeat my CSF again? Should I repeat the cultures, look at urine? Should I look for any fungal balls, do an ultrasound of abdomen, and then add fungal, wait for the reports, and then see what I should continue?
So very nicely stated. So basically, you have a clear-cut guidelines for not very clear-cut, but of course we have recommendation from both IDSA and ESCMID that if your fungal infection is more than 10% for IDSA and European Society says 12%, you should give fungal prophylaxis. So we usually prefer the third one, so which is a risk factor based use of fungal prophylaxis, because we don't have a very high incidence. But sometimes if we, in 2 years to a few months back, also we were getting a lot of fungal cases in preterm babies. So in that period, during that few months, we started prophylaxis. So this might depend from unit to unit. And so here also, though Dr. Dinesh has clearly mentioned, so don't treat only thrombocytopenia will be always there in a fungal sepsis. So there may be cases of fungal sepsis with normal platelets. So we added amphotericin B here. Report revealed Candida albicans, which was sensitive to even fluconazole. But as there was CNS involvement, we continue with amphotericin B. And we have the privilege to have MRI in our hospital. We did an MRI on day 35, which revealed multiple ring-like lesions with so this is suggestive of septic embolic encephalitis. So Dr. Deepdeep, can you say, have you thought, do you know this term, the septic embolic encephalitis? So what are the risk factors? Is it a complication of meningitis? And particularly in this case, what is the cause for this?
So this is a baby who is having recurrent infections with various bugs. And at the beginning of the slide, I could see at the beginning when this baby was admitted, there was an echo which was done. So this is a DORV with a VSD, a PDA, and with a new onset sepsis. So entire focus has to be looked for. So fungus in a baby with a congenital cyanotic heart disease. So a proper evaluation needs to be done. So echo should be done when there is a new onset fungal sepsis that is being considered over
You
here.
want to look for vegetations, right? Fungal
Absolutely.
vegetations.
So a couple of years back, we had a preterm with umbilical lines done outside who presented with a fungal infective endocarditis with end organ dissemination as well. So septic emboli can always happen whenever there is a bacterial or a fungal endocarditis. So it's a complication of that. It's not actually a complication of meningitis per se.
Meningitis, yes, okay.
But finding like this in the MRI should also make us think about doing a proper end organ dissemination screening from here on.
Absolutely. So now there was on the day 41, so I'm not making up, this is actually what happened. You might think so many things are happening, but day 41, there was a swelling and tenderness of the right knee joint was also noted. So Dr. Tapisha, what is your thought on how you'd like to treat now this? Dr. Tapisha is very good in joint infections. Hello, Dr. Tapisha.
Yeah, congratulations on managing all these tough cases, first of all. And yeah, we all know that if there is a knee or any joint involvement in the NICU in a septic child, you have to manage it aggressively. So you have to do imaging so that you can, see the morphology, the amount of fluid, cartilage destruction. You have to involve the surgeons. And joint drainage is extremely important so that the limb function is preserved later on. Also, if it's feasible or if it's available, if you just send 0.1 or 0.2 ml of synovial fluid into the molecular joint infection panel, that's amazing for antibiotic stewardship because it has these 39 targets, it has AMR genes, and it also includes Candida. So you would know whether it's staph or it's Candida, and then you can accordingly modulate your therapy. So that's also an interesting thing.
So very point. But we don't have this joint panel available at our hospital. So we did this. So the main message what I would like to give is a cornerstone of septic arthritis. You have to drain the joint. Okay. So incision and drainage was done with a capsulotomy was done on day 42, and past culture shows the specimen shows the growth of candida also. So of course, I would suggest again this fungal septic arthritis is not that common. So what are the investigation we should send in this case? That is how you do this end organ dissemination screening. And of course, if you can highlight on the treatment, Dr. Ashish.
Yeah, basically in recent era, the fungal septic arthritis or fungal joint infections are not uncommon. And particularly those babies who are treated in the peripheries, multiple antibiotics comes with the high CRP and low platelets. And common is common, like right antibiotics were given or not, right dose was given or not. If that is not the case, then we need to look at the complication of the existing diseases. And the last would be that any other end organ involvement, I mean, deep-seated infections in form of UTI, meningitis, and joint. These three things need to be kept in the mind when the baby is sick and coming to you. So the question is, which other question is already mentioned that eye, renal, echo, and neuroimaging perfectly all right. You are looking at a seeding of this particular bug into the different areas of the body, and you look at all those investigations.
So this baby was managed with amphotericin. Fortunately, again, this baby, I would just like to highlight one thing, that septic embolic encephalitis should be considered in a baby, not only with infective, but with the congenital heart disease with arteriovenous shunt, when you have a right to left shunt, and of course, have a fungemia. So it is quite common. So you have to think of this. If there is a way to, if you can do a neuroimaging, please do it. And of course, interpret values of CSF, cautiously consider fungal sepsis whenever you have a risk factor. And joint drainage is the cornerstone of treatment of septic arthritis, because not only it helps to remove the inflammatory debris and to preserve the collagen matrix and synovium, but it also helps to provide the synovial fluid for analysis and culture. So in cases where you are not getting anything, this may be a clue to your bug. So with this, we move on to case 3. A male baby was delivered late preterm, around 35 weeks. It's late preterm, it was 36 weeks. Yeah, birth weight 2.49 kg. Developed respiratory distress soon after birth. Antenatal history was uneventful. There was a history of second-degree consanguinity present among the parents. And baby was given moist oxygen in that nursing home, could not maintain. So referred to ICH on day 1. This baby came to us on day 1 only. And there was marked tachypnea, granting was there, not maintaining saturation. So we just put the baby initially on CPAP, later on ventilator. So this was the initial investigation, which showed hemoglobin to be 14.3 and the count to be 15,200. CRP on the day 1, it was CRP 3.4, blood culture same. There was a respiratory acidosis. So initially put on CPAP, first line antibiotic started, IV fluid 10% dextro started. And after 10 hours, due to clinical deterioration, we put on the baby to a ventilator. So repeat blood counts after 24 hours shows hemoglobin to be 14.7 counts, 19,300 with the neutrophilic predominance. And the CRP now is 93. So will you upgrade the antibiotic, and what you will do, Dr. Dinesh, please?
See, two things. Like any child, see, late preterm child having respiratory distress is not very uncommon. And when he started with distress, it's like whether it's TTN, though the X-ray was a little bit not very clear, but is it a TTN, whether it's a part of pneumonia or RDS, is a possibility to keep. But all of them, we screen them and put an antibiotic, because pneumonia is one of the differential diagnoses, because not all of them will have any mothers may not show all the risk factors. So we usually put them on the first line of antibiotics every time. So now when a child like this sort of, now the first line of antibiotics, I think in the earlier talks also we talked about it, is with the rapid, resistance bugs happening in the units, and what we're getting colonizers from the mothers, which are also multi-drug resistant, which is varying from unit to unit, because what you are seeing, whether what is your first line, is it like in absence of risk factors, maybe some units would be just starting with the plain aminoglycoside to sort of some would sort of, if it's getting sicker, then probably we'll go ahead and start with piperacillin tazobactam. So once the child is like this with a high CRP and a platelet 1.2, getting symptomatic and getting worse clinically, yes, we would upgrade the antibiotics. But I would have started antibiotic at first day itself now, and which would be a simpler one because I would have not considered anything major happening, but it's deteriorating like that with this marker, which I wouldn't have expected this child. I would go for a higher antibiotics.
So Bactec came negative, urine culture was also negative. So we just continue with the first line. So day 4 not improving on a ventilator. So this is the X-ray. Any further investigation? So if you can remember the X-ray, before it was like this, and now this is the X-ray. So we did an echocardiography, which came out to be normal, ultrasound also normal. You can see the liver is on the right side. We did a repeat Bactec. So we didn't send because the baby was ventilated. So we sent an bowel culture, which came out to be Enterococcus durans. Devdeep, would you like to comment on this bug?
Well, I mean, this is not a common bug in any NICU or a bug which causes infections commonly in neonates. So, but bronchoalveolar lavage is supposed to be a aseptic procedure. So all precautions would have been followed when the bronchoalveolar lavage was collected. And here with a pneumonia, which is consistent, or a consolidation actually, which is continuously changing its position, and the child being very sick, I think we should consider treating this enterococcus over here and see how the child does from here onwards.
So basically, the baby had a delivery in a local nursing home. So maybe, I don't know. We have never seen this bug also. So, but we just treated according to the culture sensitivity. So we changed this to TICO planning according to sensitivity. And baby was kept in left up position because you can see there is a left-sided problem. So left up position and chest physiotherapy started. After 48 hours, there was again change in the site of the opacity. Now, what are your thing and how will you proceed?
So here you could see that there's a change in collapses, recurrent lung collapses, whatever the dependent position, as you're saying, is getting collapsed, so left side, right side. Sometimes, persistence of infection can give rise to the change in the, so the mucus plugging moving from one side to other. One is to treat the infection. You got the organisms, you're treating it, so that's what's there. Sometimes we think about inhalation antibiotics. You think about trying to do proper sort of, something like N-acetylcysteine sort of nebulization or 3% sodium chloride nebulization. This is sort of treating the cause. But what happens, is there a root cause for it is the next thing which will come because a newborn, I'm not sure whether you talked about the consanguinity, but things like cystic fibrosis is one thing which can present with recurrent lung collapses. And second thing is things like ciliary dyskinesia is also another one which can present with recurrent lung collapses. These are something which you would...
Here the liver was normal and the echo was also normal. So we initially thought of primary ciliary dyskinesia, and we used to do a cystic fibrosis gene. So we planned of that. So, but as the echo was normal and the liver was in, we thought to send for a whole exam sequence.
Bronchoscopy was thought of?
Yes, sir, bronchoscopy, but we had in very young, it's below 3 years, we don't have the scope to. So usually we do bronchoscopy in above 3 kgs.
CT chest to rule out other things surrounding the bronchus and the lungs, which can keep on pressing the one or other bronchus.
Yes, sir. Sir, so for us, it was better to send a whole exome sequencing because we couldn't do bronchoscopy, and there was a family history of cardiacs among the siblings present. One of the sibling. So we just but echocardiography came out to be normal. So to our surprise, this came out to be this. So if Dr. Tapisha, if you can interpret the result.
Yeah. So this is extremely interesting. So basically, exomes are about 2% of the whole genome, and exomes encode all the proteins in the body. So almost 85 to 90% of the mutations causing diseases would be in the exome. That is why we do a whole exome sequencing. We don't do a whole genome sequencing. Now, this tells us about two likely pathogenic variants. One is, of course, PCD, primary ciliary dyskinesia, which is there in this child. The other is dilated cardiomyopathy, likely pathogenic. So this is something that one has to look for in the coming years, because I think right now the ejection fraction, everything is normal. And there's a
Yes,
strong
was
family
one.
history of cardiac disease.
Yes.
So this is like a Janpatri, a Jan Kundli.
Yeah.
You have to look for
So
DCM in the coming years.
so now with the advent of this taste, I think we are diagnosing more this. So baby was continued with TICO planning, postural change was done, and chest physiotherapy. The party was counseled, and this was the repeat X-ray. So the learning point is non-response in a case of pneumonia is not synonymous with antibiotic resistance, though we are speaking in an ID forum. But we have to think of the sepsis mimickers, and you have to always look for complications, search for unusual bugs, search for underlying congenital anomalies of the diseases, and sometimes rare diseases. Then only we will be able to do proper justice to the antibiotic use. Otherwise, just going on increasing the antibiotic will not make us. So it should be thought, PCD should be thought in any unexplained respiratory distress in a term unit, especially if it is associated with situs inversus or heterotaxis syndrome and CHD. But mind that these are not always absolute criteria to diagnose a PCD. In some rare cases, you can also get neonatal hydrocephalus associated with PCD. So coming to the case 4, so term baby birth weight 2.9 kg on breastfeed presented on day 21 in the month of November. This is an old case, 2023, with cough and cold and respiratory distress, and there was a history of fever. So this was the X-ray. This total count was 4,350 with neutrophil 50 and lymphocyte 45 with a CRP 73. This was the chest X-ray on admission. So of course, again, the same thing started. Baby deteriorated rapidly. And within 24 hours, intubated, ventilated, though the X-ray was not that bad, gradually becoming worsening. So antibiotic upgraded, though I will say it may not be justified because the blood culture report was showing no growth, no clinical improvement. So what are your thoughts, Devdeep, on how to investigate further?
So this is November, so this is the beginning of winter, and it's a very short duration history of fever and cough with nothing else there in the history that's provided. And if you look at the counts, it's slightly on the lower side. So lower TLC will make us start thinking whether it's a gram-negative organism or a viral organism, and a CRP which is slightly elevated. But there was a quite a rapid progress as we see in terms of how the X-rays deteriorated over a period of time.
So how you will investigate? So you'll send a PCR?
So yes, at this point, I will start thinking about definitely start thinking about sending a PCR and taking a call from there regarding upscaling antibiotics or adding anything else.
So, Dr. Tapisha, you are an expert on this. So, what will be the ideal specimen? And what is the role of respiratory panel in this neonatal pneumonia?
Yeah, so the role comes in a severe pneumonia which is not responding, and of course this child is ventilated, so you would utilize the pneumonia panel, would send a bowel fluid. And what happens is that interpretation of pneumonia panel is still unfolding. What is known is that if you pick out one organism, it has a good sensitivity, it has good predictive value. And another thing is that you need to always interpret the results in the clinical context. So this is the age for severe RSV infection. This is newborn, month of November. It started with running nose, not responding to antibiotics. So definitely you have to give importance to this particular report.
Okay, so point very well taken. So we don't take it as a non-pathogenic, right? So what are the organisms which, if we get, we will always think it to be a pathogenic? Especially suppose in a better child who is not ventilated, we have sent an nasopharyngeal swab.
Yeah.
And so in that case,
So in the upper respiratory panel, if you get influenza, it's always pathogenic. If you get human metapneumovirus, it will always be pathogenic. These two will always be pathogenic.
And of course, if you get a Bordetella?
Of course, yes. Amongst bacteria, yes, Bordetella.
Okay. So any role of ribavirin, Dr. Dinesh?
Yeah, I think, see, when it comes to the PCR panel, I think it's especially we have seen all these waves of COVID, then we had this adenovirus, then we have RSV season. Especially in those type of seasons, whenever we get these children with pneumonia, in both PICU and NICU, we end up sending this panel. And during that season, probably, especially with RSV, In a neonate who lands upon a ventilator, we do definitely treat them with ribavirin. Though I think there have been cases where people were, it's not a very safe drug. It has its
Yeah.
sort of challenges, hemolytic anemia, mucositis, and other sort of complications. But I think that is a drug of choice when it comes to neonatal pneumonia with RSV positive. Sometimes in sick, so the recommendation is in the sick newborns with RSV. You can use them. We have been use them because we've seen all the epidemics, in
So
the
will you
last 5
stop antibiotic in this case?
I can't do it. They're very brave people. I don't want to speak lies in the forum, but I think many people, I think it predisposes you to secondary bacterial infections. I think
Yes.
what is very important for you is to see, okay, I think this child had a high CRP and other things.
Yes.
You had this thing. So some people might bravely say, oh, I stop antibiotics and see, but that stuff happens in real life. You probably downsize your antibiotics. You probably not are on the high-end antibiotics. You're not on your meropenem, cholesterol, and other sort of things because you are said, keep fine, this guy. But you're not going to say, okay, I'm off everything and just continue with only one drug. If I'm PISU, maybe yes. Again, there are other factors. Am I hemodynamically unstable? Is it a single organ involvement? Is there a multi-organ dysfunctions? These are the other things which will tell me, what is my going to be my antibiotics thing. So I think it's not a straight answer. It is a child as a whole which will make a decision, antibiotic decision.
So we have to remember this influenza and RSV, they can often be associated with a co-infection. But if you are, once the baby is stable, you can stop. But in a very sick baby, I think it's better to continue. And these are the indication of ribavirin in neonates. So baby, though no clear-cut guidelines, but baby on mechanical ventilation, or if there is a rapid progression of disease, it's better to give ribavirin. And we gave, and this is the post-ribavirin X-ray, received ribavirin for 5 days and extubated, and the baby went home. So consider viral infection whenever there is an inadequate response and to antimicrobials. And one of the most important cause of, so you have to remember viral infection is one of the most important cause of culture negative sepsis. Utilize PCR if you have the facilities, and ribavirin. In the forum, I would say it is not routinely recommended in babies with RSV infection, only rapidly progressive disease or in ventilation you can think of. So we have to go a little fast. So this is another 31-week preterm HGA baby, twin one. The twin two was stable. This twin one respiratory stress soon after birth. Investigation outside showed an echo of 4 millimeter ASD. Brain USG showed a periventricular flaring because the baby was depressed during delivery, required bag and mask ventilation, and so there was a periventricular flaring, and there was no bleed as such. So course outside, the baby was put on CPAP, TPN, there was icterus, and there was also thrombocytopenia. Then they started feed weaned off from the CPAP and HFNC, but the platelet was constantly dropping. So transferred to our hospital on day 8 with there was jaundice, mild hepatomegaly, raised GGT. Total count was 6,025, CRP 12, with a platelet count of 23. So is it sepsis, or should we give antibiotic or antifungal in this case, Dr. Ashish?
Again, the $1,000,000 question to start antibiotic or not. But looking to overall the senior babies, otherwise keeping well, feeding well, had some respiratory distress to begin with. But now current issue is only two. If you want to talk about antibiotic, you have got hepatomegaly, and second is you have got thrombocytopenia. So in fact, I will be talking about some congenital infection, and for that matter, I will not be starting antibiotic. At the most, if my colleague is saying that why not to start antibiotic, I say send the culture and wait for the reports.
Absolutely. So we, in this era of antibiotic resistance, we have to practice antibiotic. This baby is not sick. In contrast to the other babies, this is a stable baby. So I think withholding antibiotic will be, and of course, antifungal. So send a blood culture and see the report and do. So this is feeding orally persistent thrombocytopenia. So what other investigation, Debdi, would you like to say in this? Sir has already mentioned. So congenital infection. So would you send the entire panel, or would you like to send a specific thing?
So yeah, I'll consider sending a torch at this point and seeing what's happening with it. So
So though we send torch, now it is better always, it is all
Also the
said, it is
CMV
better
DNA
to send
PCRs
a
as well.
particular, because this baby has many things. So we just to rule out there is no infection, because we are withholding the antibiotics. We also did a procal. It's not very costly in our setup. That's why we did it. Maybe in somewhere we wouldn't have. So backtech came out to be negative, and we send a CMV IgM came out to be equivocal, and so we send the urine DNA PCR. I'm sorry about the quality of the report, because this baby got discharged and I had just a Xerox copy. I could get it from the file, and it shows the CMV PCR was to the tune of 1,467,200, 14,67,200 CMV PCR. So this is what needs a treatment. So we considered congenital CMV whenever you see a microcephaly, SGA, thrombocytopenia, hepatosplenomegaly, and if you get an isolated sensory neural hearing loss. In fact, this baby did not pass. So we sent for an auditory, the baby did not pass. And abnormal neuroimaging may be consistent with cytomegalovirus. Here, in this case, the MRI was normal. And we sent a sample for virus isolation. You have to remember, to diagnose it to be a congenital CMV, you have to send it within 3 weeks of life. Otherwise, it can be a perinatally acquired. So how to manage, Dr. Dinesh?
Yeah, hi. So I think, see, the two things, this child, I thought when they had a UGR with abnormal Doppler, I thought there was enough reason, other reasons for the child to be IUGR.
Yes.
And put my money on torch as the first thing was little bit these things, unless there was, the hepatomegaly was probably was a clue, unless you have an abnormal liver function test or something in the eye or something in the hearing, unless it was a late
So
on.
it has an abnormal liver function. There was a conjugated hypobilirubinemia and a raised GGTs.
So I think that was the clue. So what we are actually seeing now within is perinatal CMV or sort of a postnatal CMV, especially in the extremely low birth weight babies. So we see a lot of children, smaller babies also having this is one of the problems which we are seeing. So the congenital CMV, as you said, could present like this with isolated thrombocytopenia, slightly abnormal liver function test, and a growth retarded baby. And then you look for this. If you have a count like this, we put them on antiviral, we put them on, ganciclovir or vancomycin and monitor their colony count, and gradually we stop them. Usually sort of ends up sort of giving for 4 to 6 weeks. And but postnatally acquired CMV is also sort of one thing which we sort of see in the smaller babies. That's why the less than 1 kg, sometimes we do screen the mothers if they have any active infection. And also when we are giving blood transfusion, we try to give the irradiated blood. So these are some common problem which many units who are sort of, doing sort of this thing. If you look at earlier recommendation, is to say only if you had evidence of neurological or eye lesion, then you go ahead and treat it. But currently, probably going more on the count and then go ahead and treat them. And so this is what sort of I would have gone ahead and treated with this child and take it forward.
So we treated this child with Valgan, and we repeat CMV. So in between we repeat it, it was high, 3.22 lakhs. Another week, after another 1 week, it was 1,244. We advised to continue it for 6 months. So now, as you clearly mentioned, now in symptomatic infection with any at least one organ damage, you are going to treat this. And if there is asymptomatic infection with isolated hearing loss, the treatments is still now controversial. So with this, we move on to another case, a 37-weeker with a history of respiratory distress soon after birth. There was meconium stain liquor, recurrent hypoglycemia since day one episode of subtle seizure on day 1, started on cefotaxime, changed to meropenem and amikacin on day 2, referred to us on day 4 on meropenem, amikacin, and cardinal phenobarbital. We also encountered hyponatremia and hypoglycemia. We just corrected that. We did a lumbar puncture which cells. I'm just not mentioning the other. It was a sepsis screen positive. Lumbar puncture showed 630 cells with a 65% polymorphonuclear, and with glucose being 27 and protein base 200. And it's a full-blown case of meningitis. And the blood culture grew this. So coming to Tapisha, what is this? This is a Klebsiella pneumonia.
Yes,
Going into
yes.
blood.
So the blood culture shows Klebsiella pneumoniae. And if you look at the meropenem MICs, then you find meropenem, imipenem, ertapenem, all are resistant. So this is carbapenem resistant Enterobacteriaceae or Klebsiella pneumoniae. Now, if you look at the data from our country, as far as ICMR, it is almost 50% are carbapenem resistant. But if you talk to microbiologists, they say almost 80 to 90% are carbapenem resistant. Now, what is the mechanism behind resistance? It's usually a carbapenemase production. So either OXA or OXA plus NDM. So if you look at this report, you will find that ceftazidime avibactam is resistant. And if you look at the ertapenem MIC, that is more than 8. So ertapenem MIC more than 0.5 is a pointer to the fact that this is a bug which is producing carbapenemase. That is how you find that out. The other mechanisms, though rare, are through porin change or efflux. Those are rare. So this is a carbapenemase producing Enterobacteriaceae or Klebsiella. And as you can see, ceftazidime avibactam is resistant. So this is an NDM producing Klebsiella. So when you have an NDM producing Klebsiella, the drug which will work is aztreonam. So in your antibiogram for Klebsiella, aztreonam should also be there, though it is not here. So in NDM producing Klebsiella, the right combination is aztreonam plus avibactam. So just to get avibactam, we take ceftazidime avibactam. The rationale for that is because many times the Klebsiella is not only producing NDM, but is also producing ESBL. That ESBL will neutralize aztreonam. So you need to have a BL inhibitor with it. That's why you need the combination of aztreonam avibactam. This combination is available outside, is getting available in our country. A large drug company is getting this combination out in the coming months. And that's when this would be available to us. And then we can use this for this particular condition and it would be effective. So that is what we should be doing here.
So do you advocate this expert carba test for knowing these resistant bugs?
Yeah,
Do you advocate this?
so there are two ways of finding out resistance. One is that once your culture shows a beep, you do a BCID panel and you grow the bug and you know the genotypic resistance. The other is once you have a culture growth on your plate, then you do a phenotypic resistance through expert carba R and you find out whether it is a only OXA producer or OXA plus NDM. But most of the isolates in our country are now NDM producers. So if you're thinking of Klebsiella, resistant Klebsiella, aztreonam avibactam will be a good combination.
Good combination. And this report shows this is tigecycline sensitive. So Dr. Dinesh, can we add tigecycline in this case?
Yeah.
So how good for CRS infection TJ is?
See, tigecycline is more of bacteriostatic. We
Yes.
have been going through this. I think the era about using tigecycline, colistin, or giving sort of intraventricular colistin and other things. But as Dr. Tapisha has rightly pointed out, using combination of ceftazidime with aztreonam seems to be what we should be heading it because we're finding many. Having caution that this drug should be used only once you have a definitive culture, which is saying that you have carbapenemase resistance. Because what has happened is I see some of the being using empirically this combination because this is working against because we find okay Klebsiella is a common organism and they are carbapenem resistant, so they do scope. So that is where we are going to find that even this is not going to work. So a combination of this is what would be there when you have a set high degree of carbapenem resistance in this. Now, there is an age when you choose tigecycline, but I think at this stage we are using this combination. What you, Dr. Tapisha says, after the bactam plus aztreonam in this type of children. But again, when you have a neurological manifestation, you have to look for is the ventriculitis is there, whether they need a intraventricular sort of medications, because otherwise they may not sort of respond to it. And that's sometimes some of these children respond.
So this baby was also sensitive to gentamicin. So
yeah, is the intraventricular aminoglycoside also
intraventricular aminoglycoside is a good option. And as mentioned by Tapisha, so NDM is the commonest resistant gene we get. It's better to give aztreonam and ceftazidime avibactam combination. We do it in 2 channels simultaneously. We give it, and there may be other resistant genes, and these are the antibiotics suggested for that. For KPC, you can give for meropenem, barbarobactam. I don't think it's available. So for others, you can go for ceftazidime, avibactam combination also. So we did a cranial ultrasound, which shows dilatation of ventricles, but no classical features of ventriculitis. So of course we did an MRI, but we couldn't do the contrast. So we were not able to exactly say whether there was ventriculitis or not, but it revealed also a hemorrhage also. So this was because this baby had a birth asphyxia. So the MRI revealed not only dilated ventricles, but an intraventricular hemorrhage. So we just continued the antibiotic. And this baby is still now in our hospital. And we had a plan to repeat a lumbar puncture at the end of the therapy. We have planned to give it for 28 days. So this is, I think I would highlight, Dr. Ashish, you may highlight, this is only one place in pediatrics where we do a repeat lumbar puncture, and that's it, a repeat lumbar puncture at the end of therapy, and that too, that is a newborn. So your comment on that, sir. So do you routinely do a lumbar puncture at the end of therapy?
Yeah, we do routinely just to make sure that the number one in current era where we are not sure about whether the antibiotics are going to work or not. So that is one thing why we need to repeat this. And second thing, we're always concerned with ventriculitis. Baby will seem to be looking better, but then there are things are getting better, but the cellular reaction is still there. So to rule out all those things, we need to look at a second CSF before stopping antibiotics. That is what we prefer. Maybe 7th day or maybe 14th day, there's a different thing and unit protocol. But as a rule, second CSF is compulsory. That's what I feel.
Yes, absolutely, sir. So with this, we have another case, a known case of Pierre-Robin syndrome with history of birth asphyxia, had aspiration pneumonia, came in gastric condition to our hospital, intubated, put on conventional ventilation, couldn't maintain, shifted to high frequency, IV meropenem started, no improvement. Should we add colistin? Usually the dictum is we add colistin. Devashish, Dev, would you like to comment on this?
I would wait for a bug in a blood culture or a bronchial lavage before I upscale antibiotics. I mean, rather than just routinely going up to colistin over here.
Yes, absolutely. So at least in our institute, we try to find out the bug and add, but usual practice is to just add on this. And I would like to say, you might be thinking that why you are getting so unusual organism. As you have seen, most of our cases are outborn, comes after a little bit shorter or a longer stay in nursing homes. So they come with unusual bugs like this. And but our inborn patients, if they comes to NICU, we hardly get any bugs. So blood culture was sent, and this is the blood culture report. I think I would
This is ball culture.
the ID specialist to comment on this, not neonatologist.
So Dr. K, I think this is ball fluid culture. And it is showing a good colony count growth of Acinetobacter. So we would think that it is pathogenic. And crab is essentially a dangerous bug, and almost 80 to 90% are carbapenem resistant in our country. And despite
crab is carbapenem and resistant
Acinetobacter baumannii, and despite the best antibiotic choices, almost a 40% mortality is reported.
Yes.
So if we look at this report, then we know that this is, of course, carbapenem resistant. So what is the backbone of therapy in Acinetobacter? The backbone of therapy is sulbactam, which is a beta-lactamase inhibitor, which is supposed to have excellent activity against Acinetobacter. And even if the MICs are high, for example, it is more than 64 here, the recommendation by IDSA is to give high dose extended infusion sulbactam. Now, sulbactam is also available as a standalone drug, and you could just get sulbactam alone, which you start in 200 milligram per kg per day in 3 divided doses, and you give as an extended infusion. Also, another dictum is never use a single drug. So the combination has to be with a second line drug, which is either a polymyxin or a tetracycline. So if we see in this report, you can see colistin and polymyxin are reported as intermediate sensitivity. So as far as CLSI is concerned, any colistin or polymyxin isolate MIC less than 2 is taken as something that will work. There is no sensitive breakpoint for a colistin or polymyxin for Acinetobacter. Less than 2, intermediate means it will work. So we have to give a high dose sulbactam plus polymyxin. If you go by IDSA, it prefers polymyxin over colistin, these two. And an important point to remember is that colistin and meropenem will not work in Acinetobacter. So that combination should not be tried. As you rightly said, look for the organism. One interesting thing here that I see is sensitivity to trimethoprim sulfamethoxazole. So this could be used as an add-on drug, not as a standalone, obviously, because trimethoprim guidelines are only in, say, UTI by Acinetobacter. So did you use this drug?
So
What was
in
your
this
experience?
case, actually, we used colistin, and because we don't use much of polymyxin, we maybe the cause of toxicities. But we have used colistin. So we have used colistin and trimethoprim salmeterol in this case. And in fact, I would like to share with all other colleagues that we have got a very, very good result in this. And this baby improved. In fact, when I came to the NIPID in last weekend, this baby got discharged early morning in the Monday. And so it is such a good. So I think we should we should trust our microbiologists, and we should see the culture sensitivity, and rather than always thinking of to give this or that, you should go by the report sometimes, and you will definitely win. But not go blindly. I will not say to go blindly. Use your brain also simultaneously. So this is an. So have you? Any one of you have used this trimethoprim sulfamethoxazole? Yes. So maybe the.
Used in Stenotrophomonas maltophilia. That is one thing where probably it works well.
Okay, so you have to get the right thing. So this is the repeat X-ray, and just before going, they had another X-ray which I don't have. So coming to this Stenotrophomonas maltophilia, this is the first time we have got this bug in our NICU recently on the 16th of June. This baby also again multiple admission outside. Admitted for hypoglycemia, hyponatremia, and marked leukopenia and neutropenia. And blood culture was flagged, and we started the first antibiotic, first slide, and the blood culture came to be Stenotrophomonas maltophilia. So, sir, Dr. Dinesh, please, if you can highlight this.
Instead of it comes, though at one time it used to look unusual, but it is quite commonly found nowadays in bugs. I see both in NICU and PICU, this bug is coming. Usually comes wherever there's a lot of moisture and other things. So you have to go back to see your unit where it is near your wash basins or where your suction catheters and other things. It probably gets colonized. Your hand washings are not good in the unit, and and yeah, it's a resistant, but it responds well to fluoroquinolone and trimethoprim sulfamethoxazole combination. So identifying it early and treating it is important. But though nowadays resistance to this is also being found in them, and we need to go. And I agree with what Dr. Tapish has said. So we did find some very, very challenging Acinetobacter crabs, and also very resistant. This seems to be a very friendly bug to you, what you got, Stenotrophomonas. But there are resistant Stenotrophomonas which are being reported now, which are hard to treat. And that is where you will have to go to all the combination, Dr. Tapish. I don't want to repeat again, but yes, we do. And usually when you find that, you always go back, try to take your surveillance culture, go back to your hand washing techniques and see what can.
Absolutely. So this is a gram-negative bacillus which is inherently resistant to antibiotics, and there are reports of outbreaks. So if you get this bug, you have to be careful. You have to do all this containment, and so isolation of this bug, isolation of the patient. So reduction of nosocomial infection is very, very important. And now for that, you have this A, B, C, D, E. So reduce antibiotic use in mother and neonates, do blood culture, and of course, have the habit of doing culture of everything, blood, urine, CSF. Always clean hand. Proper hygiene is the most important thing. Clean hand, clean surface, and clean procedure. Devices. So this can be from the devices, as Dr. Dinesh has mentioned. And design of the NICU is very important to prevent nosocomial infection and promote enteral feeding. So remember this A, B, C, D, E of this, so that you can carve down on the nosocomial infection in your unit. So before we end, I would like to give the key messages. Sepsis is the major contributor, and sepsis-related mortality, we have to think that it can be prevented. Remember this: prevention of infection, early recognition, aggressive supportive, rational antimicrobial therapy. Blood culture is the gold standard for diagnosis. Think of viral infection or fungal infection, and also sepsis mimic in culture negative sepsis. We recently had a case of primary HLH, which we have proved by genetic also. And sometimes the inborn errors of metabolism. One of the baby came out to be a zinc deficiency, which we thought initially to be a sepsis. So find out those sepsis mimickers and rule out those. Consider fungal infections whenever there is non-response and there is risk for fungal sepsis. Judiciously use antibiotic, escalate or de-escalate according to culture sensitivity. Use molecular test if it is available to find out the drug-resistant genes, and use appropriate antibiotic. It will help you to do antibiotic stewardship. And also use PCR in case of you are thinking of viral pneumonias or atypical organisms. Source reduction is the cornerstone or management of any local collection of pus. So just don't focus only on antibiotic. Do source reduction and practice ABCDE to prevent hospital-acquired infection, because where from this neonatal babies are getting the infection, it's either from the mother, from their own colonization, or from the hands of the caregivers. So we are often at fault, and we unnecessarily give the bad organisms, bad bugs to this neonates. So with this, I would like to end. I would request if my panelists want to add. So I just put on. And this 10 points I have put because, sir, I think Dr. Balasubramaniam is here. Sir, this is an take from your side. You always give 10 commandments when you end and give 10 key messages. So I could find this 10 points to be very, very important and relevant to a neonatal infection in the NICU. So Dr. Ashish, would you like to add something?
Not perfect. I mean, nothing to add.
Can you stop sharing?
Yeah, just want to add one thing, that when you find antibodies are not working in a given case of proven sepsis, always thought of genitourinary, musculoskeletal, joints, and meninges.
Yes.
The bug will be sitting there and will not allow to be effective. So try to look at the deep-seated infections when in a given proven case of sepsis, antibodies are not working.
Yes.
Never think of antibiotic resistance every time.
Yes, sir. In fact, we do CSF every time. Recently, we had a case of high CRP, high total counts. Nothing was getting. So, but the CRP was constantly high. And then we did a little bit restriction. There was no swelling, a little bit restriction on and a little bit crying while just handling the hip joint. And we found it to be a septic arthritis, just diagnosed yesterday. So always look for the joints.
In our nursery, I hang them from the axilla and try to see they are moving the limbs or not.
Okay.
And at least 3 or 4 times, it has come to a knowledge that hip is not moving, and they look at the ultrasound, the joint is full of pus or there is some effusion. So many things happen. Or you ask for the urine culture, it is coming positive. The mother will say that baby is passing in normally, but we say, yes, that is what I want to prove. And then urine is positive strongly. So these are uncommon things, but always keep that in mind.
Thank you. I think over to the organizing committee, Dr. Chetan or whoever is there.
Yeah, can you just stop sharing?
Yeah, yes.
Yeah, fantastic. There's no other word I am finding. Excellent case collection. It was really an amazing journey, how you could really negotiate through this neonatology and infectious diseases. Wonderful. Like you can't expect more than this from any one of our moderators. Best
Well done,
session, I must
great
say.
one.
Yeah. So yes, of course, and most importantly, icing on the cake is Tapisha's comment. It's so much deep and very crystal clear. Like I think we need to listen again and again what she explained.
We learned something from her today. I must say that.
Thank you.
Actually, and what we could get from the experience of this experienced neonatologist, Dr. Dinesh Chilla, because whatever you say, they have seen it. right? And they guide Dr. Ashish Mehta. I've seen him working personally, because even at this point of time, he must be taking one more round in the hospital and then will go home. So that critically is about his patient. What he showed, that hanging the baby, it's very really true that he shows that that's what practically he is so sound in clinical knowledge. And Devdeep, your comments were extraordinarily useful. So overall, it was wonderful session. Of course, I would like to go to first our chairperson elect, and I think meanwhile I'll look at the comments of the YouTube. Dr. Gorpade sir, please. Dr. Gorpade?
Yeah. Yeah, it was a fantastic collection of the cases. Really, how we are struggling in NICU. Whenever actually we were hearing through the cases, really, I was wondering that whether I am working in NICU and facing the same problems in day-to-day practice. And with your collection and the expert comment from Ashish, who is just so practical and handling such a beautifully in a so with the busy schedule, with the expertise from Dinesh, make a very well fruitful discussion. Of course, the young Devdeep, actually his timely comment also make the interaction more useful. And of course, the Pisha, actually same model we actually made 2 years back with the Jaydeep. Actually, I remember the resistant bugs and the newer test and your report, thorough scrutiny of reports can do a lot of things rather than going for directly expert Karba 2. Because that comment is very fruitful, because every time expert Karba may not be available at each and every place. Of course, in Metro it is easily available, but whatever the KPC or Klebsiella now producing the various enzymes, and that is number one. And you highlighted that genetics of the organism is more useful, because that depends upon the drug susceptibility nowadays. Really a new insight in the part of the resistant bugs, what we are facing about the MRSA and Enterobacteriaceae, especially Klebsiella, Acinetobacter, and E. coli like that. Really, we enjoyed, and I really personally enjoyed this panel discussion today, because I'm working in NICU, PH, and infectious disease in combo, and with all your expertise, really learning session to all the colleagues across India. Thank you, well done, and of course, really fruitful and learning session today. Thank you very much.
Thank you, Dr. Gorpade. And there are a few comments in the YouTube. Dr. Swapnil Usgaonkar said, case 1, 3 weeks sudden decrease feeding, decrease urine output, congenital adrenal hyperplasia, salt wasting type needs to be considered. That is what Dr. Ashish Mehta also highlighted. Then there was Dr. Ashwini Kumar said, majority of the studies of the CSF glucose suggest to ignore the lower values unless sent in fluoride. Any would like to comment upon that?
Yeah, CSF glucose never goes into chloride, but it goes into the plain container. Important is that you need to correlate with the serum glucose, I mean blood glucose. And that blood glucose need to go with the fluoride bulb.
Right. I think that's what you must be like. There's a ratio has to be calculated, right?
Yeah. Sometimes the ratio may not be, because in sick babies, the ratio is not considered. That you have to understand. Okay.
Yes. Okay. Dr. Charul Mehta has commented, we have one newborn who has 2 separate CSF cultures showing crab and Klebsiella. Both have intermediate cholesterol sensitivity. Yeah, Klebsiella pneumonia is marrow and cholesterol sensitive. What would be the combination of antibiotic therapy? Dr. Tapisha, should I read it again?
Yeah,
So
I couldn't hear you. I think some connection issue. Yeah.
Yeah. Okay.
Please repeat.
I'm reading again.
Yeah.
We have one newborn who has 2 separate CSF culture showing crab and Klebsiella. Both have intermediate cholesterol sensitive. Crab is TG and cholesterol sensitive, and KP is marrow and cholesterol sensitive. What would be the combination of antibiotic therapy?
I think I'll ask Dr. Charul to message me and send the culture reports, and I'll tell you. Yeah.
Cholesterol is always, they will show intermediate I. It will never show sensitive. So if it is I, you can use it along with meropenem, I think so.
But is this the same baby where you are getting 2 bugs in one CSF?
It's very unlikely.
Yeah, or 2 different babies.
Yeah, contaminated.
Is it 2 different time or what, we don't know? Like what we had the other case.
So I'll need to see the entire antibiogram. So she can just send it to me and I'll figure it out.
Okay. Great. So I think I'll go to Dr. Balasubramanian sir for his key messages, carry on points.
Yeah, thank you. That was fantastic, Kay. I expected from you, brilliant. And starting from the senior most, Dr. Ashish, Dinesh, Dedeep, and the youngster Tapisha, it was fantastic. Good learning for me. But I'm not a neonatologist. Few comments. One, I don't know, the neonatologists should have to teach me. If you see the Western literature, there is so much talk about HSV infection as a DD for late neonatal sepsis. In fact, in many centers in the West, in the protocol, like we start, when we have a child with an acute febrile encephalopathy, we start ceftriaxone, we start azithromycin, we start acyclovir, and in some places they also start artesunate. Like that, but in the 8 cases, whatever she discussed, I thought HSV should be considered. In fact, the last case she mentioned, that hepatitis, in fact, in that child, in addition to antibiotics, I don't know, as a general pediatrician, probably I would dare to treat a late neonatal infection, and I would have added acyclovir. I want comments from the other neonatologists. I personally feel that HSV infection in newborn in India is underdiagnosed, like HSV encephalitis. I want comments from the experts. That's my comment number 1. Second, I saw the report of CMV IgM that should go into the Bay of Bengal. IgM of CMV is a useless test. It is useful only for donors, organ donation people. That's all. It should not be done for any newborn. Absolutely useless test. Gone. In fact, I have seen painfully at least a few cases of biliary atresia being treated as CMV hepatitis because of this IgM. So like many antibody titers for TORCH, we have PCR for everything today. I think CMV IgM should go into Bay of Bengal. Sorry for the strong comment. And on a similar note, I saw the report of urine PCR for CMV. It should be only qualitative. We don't do quantitative in urine. I saw the report. Am I right, Dr. Kaya? Urine PCR should never be done. I'm sure Tapisha would agree with me. Urine PCR is never done on a quantitative basis in the urine. Only in the blood it is quantitative. Urine PCR is a good screening test to rule out active CMV infection. So one should not be asking for titers of urine PCR for CMV. I hope all of you would agree.
Sir, the report that we receive for the urine PCR CMV, they always do quantitative.
No, they should not be done. I'm sure Tapisha would agree.
Yes. You're right, sir. It should not be done.
Should not be done. Should not be done. That's the message I want to send. Don't ask for quantitative PCR in the urine. Quantitative PCR is only for blood. Screening, it's a very, very sensitive and specific. In fact, if urine PCR is negative, it almost 90 to 95% it rules out congenital CMV infection. Please do not ask for quantitative urine PCR. That's my next comment. The other comment, of course, Tapisha was mentioning about use of a combo of polymyxin and avibactam with your aztreonam and your ceftazidime. If you have a good lab around you, you can ask the microbiologist to do a synergy test and confirm whether this combination is working. I think that should be done.
Right, sir. Yeah.
Absolutely, it should be done. Synergy test is available in many tertiary microbiology labs. You can ask for it. And if synergy test is negative, your combination is not going to work.
So it's an e-test strip which you can put on the culture plate.
Yeah. If synergy test is negative, then I think you have to necessarily use polymyxin.
You need to add a polymyxin.
Add polymyxin. And again, Colistin, I'm afraid, Dr. Kea, maybe it works for Indra, your institute, but in most places it doesn't work. Most people have stopped using colistin, and we have moved from colistin to now volumixin. I'm sure Tapisha would have comments on that. And my last comment, sorry, I tend to forget. The last comment I had noted down, in that child who had that abscess, liver abscess, Staph aureus, two things in Staphylococcus invasive infections. One, you should not forget the possibility of endocarditis. One, two, like Sir said, Dr. Ashish very nicely said, you have to do CSF to ensure that neonatal meningitis is cleared. On a similar note, anybody with staphylococcal bacteremia, you should have a repeat blood culture to ensure that bacteremia is cleared. And you should do a cardiac examination. And in adults, they do routinely in most centers, they do a esophageal echo. In children, we don't do it. An echocardiogram for endocarditis must be done. Again, I wanted to ask the neonatologists and the ID experts here. They, interestingly, in UK, they are talking about use of amoxicillin and gentamicin. In fact, Dr. Thea said in her bug was sensitive to gentamicin. I wonder whether any of these centers have got good sensitivity to gentamicin or amikacin. In fact, Dr. Kea justified addition of amikacin for Pseudomonas. I'm afraid Pseudomonas alone will never work for, amikacin alone will never clear Pseudomonas. Maybe UTI it will clear. No bacteremia due to Pseudomonas, no lung infection due to Pseudomonas will ever be cleared with amikacin. You have to use it in synergy with some beta-lactam or aquinolone. These are my comments. Fantastic discussion. I think we could see the wisdom of Ashish, Dinesh combined with useful exuberance of Devdeep and Tapisha, and of course the brilliant cases from Kea. Thank you very much.
Sir, I would like to say that we are also seeing this HSV cases. We have 2 or 3 cases we have seen. We have sent the HSV CSF PCR, and we have also got enterovirus. So these 2 viruses we have got in neonate presenting as acute encephalitis-like features. And sir, regarding colistin...
One thing, even in, of course, encephalitis is no doubt HSV. They say a bacteremic-like illness could also be due to HSV. This is what literature says. There's so much in the... Dr. Tapisha, you can add from your USA exposure.
It is said, sir, that is the commonest cause of culture-negative sepsis is viral infection. So that's what
HSV is a treatable disorder. So you should think of covering with acyclovir in any neonate,
in general,
particularly who has what looks like a late neonatal sepsis, where you're not getting a bug, something is happening. I would be tempted to add acyclovir.
You are right in saying
that should be looked at. So
you are right in saying that, sir. But basically, HSV in neonates is acquired or it is congenital. If it is congenital, it has come to the mother. So we are looking at the genital lesions or the vesicles. So and that happens within first week. If you are talking about HSV in the late sepsis, comes generally after 3 to 4 weeks. And these are the cases where you find something on the baby's skin or eye or oral, and if not, or if ignored, then in the CNS.
Yes.
So to begin with, yes, you can start with acyclovir, but then you need to look at the other collaborative signs or symptoms to continue that therapy till you get your bug or laboratory reports.
You have 3 types of neonatal HSV. One is CNS variety, disseminated one, and the skin, eye, mouth, SEM. These are the 3 varieties of HSV you get in neonate. So usually
they present beyond the first week, so with quite a fulminant multisystemic.
Sir, in the hepatic abscess, we did an echocardiography and we ruled out, sir, and echo was done.
No, I
And,
just reminded the protocol
yeah,
in
yes,
place.
I was just wanted to echo what Dr. Bala said. See,
Yeah.
we have seen quite a few HSV infections in the newborns,
Yes.
the late onset. And has been said, see, not as common that any late onset sepsis we should think HSV, and like what we do in PICU, add acyclovir, anyone presenting like that. We don't do that in newborn. But culture negative sepsis, or you do not, your septic screen is coming negative. You may or may not, because sometimes not all mother will have herpetic lesions.
Lesions, yeah.
You may or may not have herpetic lesions.
Mm.
You may or may not have skin lesions, because some of these children rapidly deteriorate. So you have culture negative, septic screen is looking, sometimes there will be liver involvement. They present with bad coagulopathy. Sometimes they have temporal lesions in the brain. And these are the babies whom we have to preemptively start acyclovir rather than wait till you wait for the herpes report to come through. And this has been our practice. So if you have someone, you are having no risk factors, your culture is coming negative, you have either a hepatitis feature, or you have a skin lesion, or you have something in the brain like seizures, then you go ahead and start them on acyclovir till you get your HSV report. That has been our practice, but it's not as commonly used as we see in the PSU setting.
Oh, well said, well said.
Comments from Dr. Darur, sir, chairperson, immediate chairperson.
Am I audible?
Yes, sir.
Yes, sir. Yes, sir. Good evening.
Yes, sir. Good evening. Initial part, I think I missed. Later on the discussion, I felt very happy. First time there were many cases of newborn being discussed and the infections. So ultimately, the day is not far off where you are going for the rounds. You will have a pharmacology person and another microbiology person. Both of them will submit their reports, where you will take the decision on your experience, because it is the more we are depending on investigations, which have become very, very difficult for a common person or a common hospital. But the specialists, they are reaching the heights just like Everest in treating the patients. So I congratulate all the people, and let us see how better it is being done by understanding these people's discussions. Thank you, one and all.
Dr. Darur, there will be one more expert in the rounds along with all of us. Can you guess who it is? It's an expert in AI. It's an expert in AI. He will come and tell you what it is.
Sir,
That's what is going to happen.
2003 when
One fellow will be there
2003.
who's trained in AI, who's a specialist in AI. He will tell you what you should do and what you should not do. I'm sure that's going to happen in 10 years.
Maybe we may not be still in intact at that time.
I won't be practicing, definitely, of course.
Yeah, that's what I'm saying, sir. I'm sharing that. I'm also joining you.
Correct.
Yeah, Dr. Malpade.
Bala sir's comment actually on that, my reaction before Tapisha regarding the molecule of the polymyxin versus the colistin. See, I am using these both molecules in so many years. See, polymyxin can cause the bad blackage discoloration of the skin. But regarding the efficacy of the both molecules, if you see that literature, actually polymyxin is nothing but it is a colistin E. It's not that much difference. Only the difference is about the nephrotoxicity.
Yeah.
Rest of the things, hardly there is a difference in compared to the microbiology and all the things. That's my opinion. Actually, Tapisha can.
But if we read the IDSA guidelines or read the IDSA documents, in treatment of Acinetobacter, they very clearly say that polymyxin B is preferred over colistin, just because there is a lot of data from various systematic reviews and studies regarding the PK parameters of polymyxin. Also, colistin issues are there in the lung. Reaching the lung in pneumonias, there is a problem with that. So polymyxin is taken first, and then colistin comes second or third after minocycline.
Colistin became famous because of the infamous NDM one. And it has gone out. In fact, I know in the Dr. Balaji of CMC Vellore, he says in CMC there is very sparse use of colistin these days. The adult ID units also have started reducing the use of colistin. and they are resorting to only polymyxin. I believe the PK/PD parameters and safety parameters suggest that polymyxin is probably a better molecule than colistin in most cases. That's what, and I have not much. I don't have much experience. Whatever I'm saying is, I'm quoting only from literature. My experience is very little.
So it was really a brilliant discussion, many learning points, and I think we need to revisit this episode again and again to get more out of it. And that's what our this thing PIDA YouTube channel is offering. That's why we get response in the morning next day. People are looking at it late night and then give it a response. How was this particular link? So that's the beauty of this particular session, which has been going to be there archived on YouTube. So thank you one and all that my respected faculties, all my ID experts, Dr. Dr. Daruru, Dr. Korpode, Dr. Bhaskar. It was really a wonderful session. Thank you all. Good night.
Thank you. Good night.
Thank you,
Good night.
everyone. Thank you. Good night.
Manish. Hello, Manish. Are you there?